department for the invitation. It's always fun to go somewhere else and interact with your colleagues and some of my ex-residents too. It's always fun to see them evolve and grow up, which is always nice. Again, I'm going to try to share with you some of my experiences with some of the research I did early on, but in a way that tries to combine basic knowledge with science and fun at the same time, and all this pertaining to your clinical practice. I'm going to try to make sure that you understand that some of the principles that I'm going to outline in the presentation do have some sort of clinical impact. So again, I worked, part of this work was done in the Concord Field Station, which is a little station outside of Boston in Concord, Massachusetts, which is like 20 minutes, half an hour from Boston. And we did all of that research there. And the idea is that I'm going to try to combine how to give anesthesia to some of these animals in the context of analyzing their respiratory system. So I'm going to give you the first patient. So read this slide. This is a classic board exam patient. Uncooperative and anxious. Difficult airway. I do have.
I'm very sorry, it jumped out of your, when I plugged this in. Let's see if this works once you get into it.
Go back. Working beautiful. Thank you. So, uncooperative patient is anxious. He's been labeled as a difficult airway. Of course, he happens to have a full stomach. There's no IV access. By the way, he happens to have the potential for malignant hyperthermia. Okay? So the resident calls you and tells you this. You know, you're like, oh my God, really? Are you serious? Is that a joke? And then to finish the whole thing, he tells you, and by the way, the patient's already in the holding area waiting for you. You're sort of like, okay, what do I have? And this is the patient. Okay? This is a pronghorn antelope. I don't know if you've seen this animal before, but it's a fascinating American native animal that happens to be probably the best runner in the Western Hemisphere. He can run almost as fast as a cheetah and keep it running for over 10 minutes. Okay? I don't know if you've seen those videos when a cheetah wants to catch a prey. The cheetah runs for 10 seconds and then stops. They basically overheat and have to stop. And that's basically an anaerobic burst of exercise. This animal can basically aerobically do almost the same speed for minutes on end. So one of the things that we have an interest in is how this animal is able to maintain such a huge aerobic capacity. And we were trying to analyze what we call the pathway of oxygen transfer through this animal's cardiorespiratory system. If you see how much oxygen we consume as a VO2 max, as a human, it's close to 1.3 mLs per kilo per second. If you see what this animal is purported, there's one measurement. This is the only study that they did before we did ours that had measured the VO2 max in this animal. And they were claiming rates of 5 mLs per kilo per second. That's very significant, okay? So we wanted to basically analyze how this animal is able to do this. Just to give you an idea, we are pathetic athletes as humans, okay? We are like a goat in terms of VO2 max. If you happen to have dogs at home, your doggies are much better than you in terms of VO2 max, just so you know, they're great athletes. Okay, one of the principles that we used to try to put this into context was the concept of synmorphosis, which basically was established by Dr. Weibel and Taylor many years ago. And they basically, the basic premise is that the animals are built economically. In other words, you have enough structure to support the function that you have. Having too much organ or structure is costly. It costs energy to maintain like a third lung or a second brain if it's not going to give you a survival advantage. So it's a fine balance in between having enough structure but not too much. And when we look at the respiratory system, we're trying to see if we could use this premise to study the design of the system. And one of the things that we do we use what is called allometry, which is trying to scale the function to the body weight. There's a relationship between the size of the animal and the function that you're trying to look at. And the relationships can be in different fashions. For example, if you're doing a log-log plot, the weight of the animal and the function, and the relationship is 1-to-1, meaning the bigger the animal, the bigger the organ in a linear fashion, you get a slope of 1. Okay? If you have a nonlinear relationship, the slope of this line is less than 1, and etc. If there's no relationship, like for example, hematocrit doesn't change with size in mammals. Okay, so you basically had a flat line. Again, this is trying to study the relationship between the body weight and the function, and to see if it matches the principle of symmorphosis. Okay, so we were talking about oxygen consumption. If you look at body weight down here, this is your plot for oxygen consumption. Okay, so you see this is a nonlinear equation, basically curved like this, and you would see that this line here, which is a linear relationship with body weight, happens to be the diffusion capacity of the lung as a surrogate for lung tissue. So we now have a scenario where oxygen consumption is increasing to body weight in a nonlinear fashion, but if you look at the lung tissue, there's a big discrepancy. So it's also growing up, but growing up in a linear fashion. It seems that, particularly when dealing with the bigger animals, we have more structure than function. Okay, there's a big gap between the two. And that doesn't fit the symmorphosis model in terms of having enough structure to support the function that we have. Here we have too much structure to the function that we have. And that's one of the bigger things that we saw when we were doing this set of experiments, that we couldn't understand initially why we have such a big discrepancy. If you look at other parts of the cardiorespiratory system and you plot, in this case we're plotting capillary volume, but it can be mitochondrial volume or any other structural parameter, the scaling or the slope that you get compared to VO2 is basically the same. In other words, most of the structures that we have in the cardiorespiratory system have been scaled in a way that match the maximum oxygen consumption of the animal. That makes sense. Again, what it didn't make sense was the lung as a structure in the respiratory system. And one of the thought process was that the lung is an interface organ. It's basically a huge surface area. You're talking 70 to 100 meters squared of surface area exposed to the environment. So that entails some dangers, and it may be that you need to have more structure to take care of the potential interaction with the environment. Hence, we have the excess structure. Again, this is how biologists try to put it into context. They have to find an answer for the big discrepancy that we were seeing. And some of it would be that, okay? Or it's thought that could be that. Another thing that we could use to see if the system is well designed and organized is basically try to see the system or study the system in a condition where the fluxes, in this case of oxygen, are maximal. In other words, in maximal exercise capacity, you should be able to see the oxygen flux through the system. And if the system is well optimized, when one part of the system fails, the rest of the system should fail as well. In other words, that means that all the structures are basically paired with each other functionally. So it's not just one area as a bottleneck, we have that the whole system is failing. And we can view that as a way to see the optimization of the system. So how do you do that? You have to basically deal with animals that really can generate a high oxygen flux. Thoroughbred horses are a classic example of animals that are incredible in terms of their oxygen capacity. Elite athletes, human athletes, are, again, they're good, but as I told you before, they're not incredibly good athletes compared to the other animals. So as a model, they don't work that well. And we have smaller animals. Smaller animals, like a shrew, are very important because they're so small that the oxygen requirement per unit of weight is very high. Like in PD, when dealing with babies, their oxygen consumption per unit of weight is high, basically the same principle. And again, it may have to do with the surface ratio to volume, heat dissipation, and potential some of the ATPases that the small animals have that may be more inefficient. Again, small animals do become a very good model for this. And here you have, I don't know if you've ever seen a shrew. They're very tiny. We have a nickel here. Okay, this is how small they are. And they're interesting animals because these animals have a heart rate of 1,200. Okay? And realistically, given their size, this animal should have a heart rate close to 1,500. What I mean by that, because they need such a high cardiac output for the oxygen delivery that they have, they need to have a very high, fast heart rate. But the problem is that you don't have enough time to conduct. Even though the heart is tiny, the conduction limits the speed of the heart rate. In other words, they cannot go any faster than this. So as an adaptation, these animals grow a bigger heart. So if our normal heart is a certain percentage of our body size, these animals have a bigger heart, so they can have the maximal heart rate that they do have with a bigger heart to obtain the cardiac output that you need. Again, animals have beautiful adaptations to maintain this huge oxygen consumption. What's the problem of starting these animals? Let's say you want to do a blood gas on this animal. What do you think is going to happen? You exsanguinate the whole thing. Just poking the animal, you impale the whole thing and the thing is dead. So you won't be able to do any more experiments. Again, tricky to handle, and because they're so small, can you put a swan to measure cardiac output in this thing? So you can see the constraints of the size of the animal. Okay? Human athletes, again, this is one of the Norwegian's cross-country skiers. The maximal VO2, which this guy has, that ever measured in human beings, close to 96 mLs per kilo per minute. This is a number that should ring bells to you because I would assume that when you're pre-oping your patient for thoracic surgery, you go through your VO2 max. What's a normal VO2 max in a patient that's going to have a thoracotomy, or that you want the patient to have to do a thoracotomy? You remember those numbers? Close to 40 mLs per kilo per minute. So the average adult male in the mid-40s should have a cardiac, VO2 max close to 40. This guy has a VO2 max of 96 mLs per kilo per minute. Okay, and despite that, you don't see some of those failure things that I was telling you about, because probably he's not pushing the system to the max if you compare to other animals. Even though it's been described that some of his patients do have some bleeding in their airways and they have some desaturation when they exercise maximally. Okay. Thoroughbred horses. This is a classic example. If you've seen, I don't know if you're fans of horse racing, but these animals at the end of a race are going to have this. This is basically pulmonary hemorrhages, okay, and it has to do with stress capillary failure. If you do ultramicroscopy of these animals after a race, they have rupture of the capilloveolar membranes, okay, and it has to do with the huge pressure swings into their interthoracic system that basically expose those capillaries to huge transmural pressures. Their PA pressures can go as high as 120, 130 millimeters of mercury, so it's suprasystemic at times, to the point that this bursts, and that's why they bleed. That's why they do Lasix doping some of these animals, which is they try to reduce their total volume to see if you can decrease the PA pressure, trying to decrease this. But these patients do have what it looks like a catastrophic failure of the respiratory system when they exercise maximally. And trying to understand why this is, look, this is a plot of the major races over time, and look at the winning time from 1930 to almost the year 2000. In terms, this is the Kentucky Derby, this is Preakness. You will see that the amount of seconds they can shave off is minimal. These animals cannot go any faster, no matter what you do, no matter how you breathe them, whatever. This is it, they reach a maximum. So that's why you can see that these animals basically fail. They reach a point where they're using everything they have. Their system is as optimized as it can get. And this is interesting because we tend to assume that a failure like this is a bad thing. You know, we see in our patients, if our patients desat, we assume that's a bad thing. I'm going to show you why desatting can be a useful feature here. These animals, these horses, when they're running, do hypoventilate, they retain CO2, they become hypoxemic because they have diffusion limitations at the lung level. Normally it's been taught that you may have in your lungs, human lungs, diffusion limitation. The reality is that you rarely have any diffusion impairment as such, true diffusion limitation. What you end up having is a lot of VQ mismatch in humans. But in this particular scenario, we can prove that these animals have a true diffusion limitation. I'm going to show you in a minute. Their capillaries and their alveoli just basically break down. And you can also have peripheral diffusion limitation, which is an entity sometimes we don't think about. When the blood goes too fast across the tissue, it may not have enough time to dump the oxygen to the tissue. So the blood coming out of the tissue still has enough oxygen that was not given. It's going too fast. You need to have an amount of time to unload the oxygen from the tissue. And that's basically something that people don't talk about. But in scenarios like this, it may be a problem. So let's talk about the diffusion limitation. This is a normal lung. This is the mixed venous of the blood entering the lung, which is close to the 40s. And as you spend time inside the lung, you oxygenate and you equilibrate with the alveoli. Normally, the transit time of a regular red cell going through the lung is what, 3/4 of a second, 0.75, 0.8 seconds, okay? As you start exercising, your cardiac output goes up. As the cardiac output goes up, the transit time shortens to the point. And the other thing that is happening is that the mixed venous also goes down. You're extracting more. So you are having blood getting into the lung with a lower PO2, and it's exiting the lung when it reaches, before it reaches full equilibration. So it shortens to 0.4, 0.5 seconds. So now the blood doesn't have time to equilibrate with the alveolar PO2, and you establish a gap. So you have an alveolar arterial difference from diffusion limitation. And again, this is very hard to get in humans. One of the few scenarios that you may see this would be someone up in Everest, where they're exercising, their cardiac output is huge, and the partial pressure of oxygen is low, hence the partial pressure of oxygen is low to diffuse air, and then you can have a true diffusion limitation up there. But in normal circumstances, unless you have a fibrotic lung, then you can talk about diffusion limitation. Other than that, it's very hard. These animals do have a clear-cut diffusion limitation.
The pronghorn antelope, a more conventional animal Olympian with 4 feet. It's the long-distance runner of open sagebrush country in western North America. These are doing exactly 44 miles an hour. Their breathing is in phase with their movements.
These are the animals being run on a treadmill.
Chasing baby bottles off and on since early last summer, going maybe a mile or two a day. 2 young orphan animals named Pronghorn and Ollie. And the thing is, they seem to love the work.
They jump right on the treadmill, and often we have to take one of the animals off the treadmill so the other one can run. I think that that's something they do naturally.
Attached to an oxygen mask and through computers and readouts, the antelope are telling University of Wyoming researchers how the respiratory system of a running machine.
This is the animal running with a swan gans on its neck. You see it? They need to run on inclines because the treadmill is not fast enough to reach their VO2 max. Okay? So we have to get tricks for these animals to go to their maximum. Interesting enough, these animals are very hard to catch. Okay? If you try to catch an adult, you'll never get close to it. So the way to get these animals is you have to get an expedition and get the little fawns or their babies. Okay? In the middle of the night, you have big flashlights. You startle them, and that's when you get the babies. So you have to raise the babies in the lab for at least a year before you can do anything. So to get 2 or 3 of these animals is a major enterprise. These animals cost $50,000 to $100,000 per animal because of the difficulties of catching the animal and then raising the animal, so you can do some of this. So that's why the data is so limited in this type of animals. And the only data that we had was from Dr. Liz, the guy you saw in the clip before. And this is some of the data that we did. But again, this is fascinating trying to do this. These animals are very nervous animals, okay? When I was saying that this animal is going to have a malignant hyperthermia, they do have what's called a capture myopathy. When you grab them, they get so scared that they develop an MH syndrome with rhabdo, and they basically can die. This is just from being nervous. So it's a very tricky thing to get close to these animals. That's why having these animals in the lab in an early age makes them accustomed to be surrounded by humans. Okay? So when I joined the lab, they told me, okay, we're going to do this experiment. We need to anesthetize this animal. So what do you do when you're going to anesthetize an animal like this? You call other zoos to see what are they doing. Guess what? Nobody knows. Nobody has anesthetized these animals. You have to create your own anesthetic. Okay? That's easy. You're experts in anesthesia. Let's develop an anesthetic for these animals. These animals are ruminants. They have 4 stomachs. They have all this ruminant fluid, which is a nasty green concussion that they keep in their GI tract. So knowing that they have 4 stomachs, instead of, if you're happy with an NPO of what, 6 hours, 8 hours, let's make it 48 hours. That's clever. Made up completely. Okay? What pre-med you're going to use for this animal? A little bit of Valium with some honey. Okay, you have to lace the Valium so they can eat it. So you give them the Valium and try to catch the animal. And look, the animal's boom, boom, jumping all over the place. Try to get close to this. This is with the Valium on board. Okay? Jumping all over the place. Okay? Finally, with more honey and more food, we're able to get the animal inside the lab. Okay? So we do a mask induction. Okay, this is a custom fit mask. This is a mask induction. The animal goes down. So now we have to secure the airway. Okay? Long neck. I had a special laryngoscope that was like 18 inches long. Okay? What a nightmare. And the reason I say this is because, for one, as you can see, I'm intubating. You see how I'm carrying the laryngoscope? I don't know if you ever intubated someone prone. Okay? When, and this is a skill that is good for you to have. Where I trained, we did this in kids. We turned them prone and we would intubate just for fun on the prone position. And the way that you could do will be with the laryngoscope in your right hand. So we're trying to do the same thing here. Guess what? Very difficult. So my super extra long tube, I had a coat hanger as a stylet to make it go. And after a few attempts, and they have this gadget that opens the mouth, whatever, that's for animals, whatever, we finally secure the airway. You can see that we're struggling to secure the airway. Then we got it. Okay, and we secure our tube. But look at this. This is supposed to be white. This green stuff is ruminant fluid. Okay? Interesting enough, this animal had, and we didn't know this because we put the animal down, we got an IV, and then, so we play a little bit with this. So this animal probably had massive aspiration. Okay? And the first animal we ever did basically had a cardiopulmonary arrest from massive aspiration. Okay? So we had to open the chest, do direct cardiac massage, inject epinephrine into the heart. A lot of fun. And we're talking a $50,000 animal. And I happen to be the anesthesiologist on this. So you can imagine how frustrating this is. Okay? So again, we decided next time we do this, we're going to do it again because we had 2 more animals. Let's be prepared. Let's create a mini ICU in the lab. You have to understand how veterinary medicine or anesthesia is done. It's very rudimentary. Okay? You don't have A-lines or swans or blood gases available. You don't. So we basically brought a mini ICU to this place to be able to do these cases. And the reality is that we learned a lot, and we were able to do this successfully many times with the other animals. Okay? So you can see this is the animal. We have EKG connected. Okay? We have, they're on a ventilator with anesthetics. We can warm up the bed. So we had all the goodies, and we had all kinds of resuscitation drugs and everything to keep the animal alive. So where do you put your pulse oximeter? Okay? Their tongue is black. Okay? And you can put the pulse oximeter on their tongue, and you get a signal. Okay? One of the things that you tend to do, these animals, when they're waking up, they get very wobbly, and when they try to stand up, they crash into things. So they can hurt themselves by crashing into a wall or a fence. So you have to wrap them until they can hold themselves. So you wrap them until they're basically ready, and then you take the towel off and they just jump. And we're checking here the pulse ox before he would start running around. Okay? And here, what you see here, we did what is called an arterial exhalation. So we had the carotid in a superficial position so we can get blood gases when they were running. And we would float a swan as well. Trust me, you cannot float a swan if these animals are awake. And this is the animal fully recouped with the swan on board. These swans will remain in the patient like for 4 or 5 days when we're capturing all the data. And we'll give them antibiotics and everything just to make sure they didn't develop Lyme, sepsis, whatever, things like of that sort. And this is the animals as they're running, and we're capturing the data. Any of these experiments will take, if you think you work hard here in the OR, try to work in the lab. There's no hours. You start one of these experiments and it can be 5 in the morning the next day and you're still working in the lab. And time flies when you're having so much fun. So we found those animals, we didn't get the high numbers that Dr. Lindsay got, but we got 3.5 mLs per kilo per second, which is 20% higher than a regular horse, which is incredible. The good news is animals were able to do this, perform better than a horse. And look at all the respiratory parameters. They did not accumulate CO2. They did not have diffusion limitation. The A gradient was minimal. The PA pressures, the highest we're able to measure is close to 60. Okay? So incredible animals. Again, this brings the level of cardiorespiratory adaptations to another level. These animals really need to have this to survive in the wild, so nobody can eat them. Okay? Coyotes and other animals that will prey on these animals, they basically cannot reach or get close to them because the animals will outrun them any day. And one of the things that we saw is that when you start plotting in here their VO2 maxes, and you compare that with the amount of tissue that they have, the gap starts to narrow. Basically this kind of gives an explanation of why these animals seem to have such an amount of excess lung structure. So the conclusion would be that in order to provide for very high oxygen transfer rates, you need to be able to accommodate by having more lung tissue. Again, these are theories, and again, it's very hard to understand the big design and the constraints of the design. We tend to assume that that could be a potentially plausible explanation. So, let's go for our next patient. What's this? Looks like an ostrich, doesn't it? It could be an emu. It's a rhea. Rhea is from the same family, a little bit smaller than the emus. They're native to South America. Okay? So this was our next patient. Okay? So the idea was to measure their oxygen capacity, but we also were looking at biomechanics of their joints as they were running, besides looking at their oxygen consumption. So again, you're bound to anesthetize this animal. You basically go to the veterinary anesthesia textbooks, okay? So when you look at the page on these animals, look at what they say. Extremely dangerous. They can disembowel you. You're supposed to have wooden shields and protect your eyes because then they poke them out, okay? So that's what the anesthesia textbook says. So, as you can tell, Dr. Taylor, being a smart guy, he was on the back. And who's in front, waiting to be disemboweled? Okay, so that's how you do research when you're a resident. Okay, that's what they have you do. Okay, so we did a breathe down induction, again, a custom-made mask for this animal, and we brought the patient down. Okay, so basically, boop, animal goes down. You notice here that it's very tricky to measure. Their thigh is so triangularly shaped that it's very hard for your blood pressure cuff to hold in position. So we had issues with the airway of the antelope. How do you think the airway of this thing is going to be? Scary, isn't it? So I had more laryngoscopes and tubes that you can think of. Okay? So we bring the guy down, and look at what happens. You open their beak, and the airway's there. Such a nice surprise. You open their beak, it's there. So that was a piece of cake. I had all kinds of stuff. I just had to thread the tube in, and that was it. Okay? So it is important because when we started trying to get a blood pressure on the animal, we couldn't get it. So we said, let's put it up here in the neck. So what's the problem here? You bet. But do they have much of a brain? So who cares? The problem is I couldn't ventilate. You see the tube that I have? You see that's an extra long tube? So what do you do with your tube? This is a long tube. Just thread the tube deeper. Problem solved. Now you have a secure airway, you can ventilate them, and you can get blood pressure measurement. Okay? So this is the type of things that you have to improvise as you're doing this type of techniques. Okay? And again, this is the animal with making sure all the vitals are good. We have equipment for resuscitation and everything. This is an animal. This is before my time. Again, the same problem. These animals wake up, they're so disoriented, they crash into things. I don't know if you've seen a horse. A horse will never go down. That's why like equine anesthesia is very dangerous, because the animals, you have to lift them up and wake them up as they're standing, because otherwise they go nuts and they can hurt themselves and the people around. They have huge padded wounds because of this. So this is an animal that people didn't take those precautions, and this is what happened. And that will tell you something. Working with this group of biologists was very interesting, because you as a physician have all the knowledge base and understanding of all the complex physiology, that you can provide a safe environment for these animals. And you can provide an anesthetic that is 10 times safer than whatever they were able to provide before. You don't underestimate the training that you have, because it will help you so much in troubleshooting all of these situations. One of the things that always fascinated me about birds is that they have a great respiratory system. Birds can fly above Everest. If I put one of you on top of Everest now, you're going to pass out immediately. And as you're passing out here, a geese will fly over you happily. Okay? Can you imagine the amount of oxygen or energy that requires? So you can tell these animals have a wonderful respiratory system. Okay? And they don't truly have a lung. They have what is called parabronchi, which is like a honeycomb stiff structure. Okay? And they have what they call air sacs. These air sacs have been designed in a way that minimize the amount of dead space. They create a unidirectional system of air trying to cut down on dead space. Remember that our dead space, when you breathe in and breathe out, having a common airway or pathway of air into the lungs, you dilute the air that is coming from the environment with the one that already has had gas exchange. So the PO2s you achieve in your alveoli are much more lower than the ones you get in the environment. So that's a very inefficient system. So if you want to be more efficient, you want to cut down on dead space. And that's what these animals tend to do with this air sac system. The air tends to go into these air sacs, goes in a unidirectional fashion through this parabronchi, and then they basically exhale out. The only common path that they have is a very distal airway as they exhale. So by doing that, you can basically get a better, more efficient level of equilibration with environmental PO2. And you can see it here. This is the human mammalian lung, where you have your FRC as a reservoir. The problem with that is that you're taking oxygen out of that reservoir. So the inspired O2 is much higher. This is environmental PO2, and this is the arterial PO2. This gap in between what is in the environment and what's in your artery has to do with the dilution in the FRC, given that you have this common pool setup. Very inefficient system, if you ask me. The ultimate efficiency will be a fish. Think about it. The amount of water, the amount of oxygen in water. These animals really have to have a very efficient system. So what they have through their gills is a countercurrent gas exchange mechanism. You remember the countercurrent that we have in our kidneys, where you basically maximize the concentration gradients? The animals do the same thing. Blood going through their gills, as they exit the gill, has the same PO2 as the water incoming into the gill. So the gap between the two is minimal. And remember, when you're dealing with extremes of physiology, a few millimeters of partial pressure can be the difference. If you, I don't know if I have the slides here, but if you look at the PO2s on someone who goes up in Everest, I don't know if you've ever seen, there was a New England Journal article of a few years ago that had some of the results of the latest Everest expedition. 4 of the guys managed to get to the top, and they got blood gases from themselves. They were basically like a few meters below the top because they couldn't stand. So there's a little balcony area where they took blood gases. So guess what they did? They pulled their pants down, and one of the guys with this syringe poked the femoral artery, and they got samples. So you have to trust your buddies if you're at the top of Everest. You're hypoxic, tired, there's wind, it's minus who knows what. And then you have a guy with a needle going for your groin. It's a very scary thing. They managed to get 4 samples, okay? And guess what the average PO2 was on those samples? Give me a number. Why do you think the PO2 of those guys was there in Everest?
40.
No, I wish. 24 millimeters of mercury.
That was good.
This is people that are functional, that are maintaining, that can do blood gases on each other. The highest was like 29, the lowest was like 19. Look at the article, it's fascinating, New England Journal, for a few years ago. So it tells you how much you can take. That's why when my residents come to me and they say, oh, the patient's PO2 is 58, and we have to go to an FiO2 of 100, I say, what? 58? That's nothing. When you tell me it's 22, then we start talking. But not at 58, and the residents freak out. Like, oh my God, it's 58, and they rub up the FiO2. Not the right thing to do. Some people talk about permissive hypoxemia. You've heard about the term of permissive hypercapnia? What about permissive hypoxemia? Again, just food for thought. The birds, though, are in between the pool system of our mammalian lung and our gills, the gills of fish. They have what is called a cross current. It's not completely counter-current, but it's cross current. But it's very efficient. The gap that they have is not that bad. And that allows them to basically go above Everest without much of a problem. I'm going to give you a third patient, okay? You have to tell me what's this. This is a carrot, by the way. Very hungry animal. What is it? It's a mole rat. It's a mole rat. These animals are interesting because they basically live in burrows. And what's the thing about living in burrows? That the FiO2 is very low. So they're very well adapted to live on hypoxic conditions. The equivalent when they're deep in their burrows of their FiO2s that they see is equivalent and higher than the Mount Everest. And we're going to talk about this in the next lecture, but it's very low. So these animals do have to have adaptation to tolerate this. Okay? One of the first things that you notice on these animals, where are the eyes? They don't need eyes. Why bother? We're talking about design. Why have eyes if you live in the dark all the time? You don't need them. Okay? So these animals do have very interesting adaptations. They have increased diffusion capacity. Their alveolar capillary membranes are very thin. The capillary density is very, very high. And they have low P50s. Okay, so their P50, which is the PO2 at which your hemoglobin is 50% saturated, is very low. If you remember, humans have a P50 of what, 26 millimeters of mercury plus or minus? Okay, these animals have a lower number than that. Okay? And why is that important? Because you need to understand what is it that the animal is trying to do. And the oxygen affinity is changing in a way that intuitively, initially doesn't make much sense. Okay? You're very familiar with what shifts the curve to the right or to the left. Okay? Theoretically, everything that changes, that shifts the curve to the right, facilitates, lowers the affinity of the hemoglobin for oxygen, and hence allows the tissue to get oxygen easier. So in most conditions where you have a problem with oxygen delivery, having a right shifted curve helps you deliver the oxygen to the tissue. Isn't that correct? Isn't that what you've been told? So that's important to understand. I'm going to go back to that in a second. So this concept is very interesting because at one time I had to measure the saturation of a set of little mice that I had. So I said, okay, how do you measure the saturation, me being a physician, on a mouse? Have you ever seen a mouse pulse oximeter? So what would you do? How would you do it? Saturation, not a blood gas, saturation. So you get the whole animal into a little clip-on pulse oximeter. You just have to make sure you take the hair off. So we got the animal with a little bit of that cream nair thing, whatever, to get the hair off. They get muted little animals. You put them in. And voila, you get a number. 85% saturation. So what's the problem? Shouldn't these animals be like us? I was thinking how valid it is to put a pulse oximeter on the whole thing. We assume that going through the finger is good. Who knows what's going on when you go through the whole body. Okay, so I was very distressed about the numbers that I was getting. It was a consistent number. I was like, what's going on? If you look at the P50 of animals, it's very interesting. And you can see that the smaller the animal, the more right shifted. This is partial pressure, this is saturation. So this will be the P50 range. So if you see the mouse, the rat, the cat, whatever, the bigger you get, the more left shifted the curve is. The smaller you get, the more right shifted the curve is. So now look at what's happening here. My little mouse basically had saturation of 85, or sorry, 85. And when you plot that down, it had a PO2 of 95. That's what you would expect. So my thing was working well. The saturation that is low is basically because they have low affinity. That hemoglobin doesn't like oxygen. Why? Because given their small size and their high metabolic rate for unit of volume, the high oxygen consumption per unit of volume, you need to have a hemoglobin that dumps oxygen easier to the tissue. Again, the same basic principle. You want a hemoglobin that downloads oxygen very easily, and that's what nature is doing when you become smaller and smaller. Okay, let's go back to the to our mole rat. The issue with the mole rat, and again, I get more numbers here for different animals. Okay, so I think size is important. Okay, and you can tell that size has a major impact on some of these parameters, and that's why allometry as a science is very interesting and give you insight of the design of the respiratory systems. But going back to the mole rat, you start thinking, okay, what's the problem with the mole rat? Is the problem oxygen delivered to the tissue, or is the problem capturing the oxygen from the environment? Okay, so if you think about it, what you have is a problem of capturing the oxygen in the environment, not delivering. So these animals do benefit from having a hemoglobin that is left shifted. So when the hemoglobin goes through the lung, captures the oxygen, and then is allowed eventually transfer the oxygen to the tissue. So the adaptations for hypoxia on this type of animals is the opposite of what you would normally expect on other species, okay? And you will see it. Animals that have they're well acclimatized to high altitude will have P50s that are left shifted compared to their peers of their normal size. Okay, so this also makes sense. The mole rat has a left shifted hemoglobin, and any other animal that lives, the vicuñas and llamas, which are also animals that live in the Andes Mountains, have left shifted hemoglobins. Okay, which makes sense. There's a beautiful experiment that they did many years ago, published in Science. We're talking probably the early 70s, where they grabbed a bunch of mice. They put them in a hyperbaric chamber. They dropped the pressure to be equivalent to Everest. All the mice died. And think about it. Mice having a right-shifted hemoglobin, that hemoglobin doesn't like the oxygen. Now you put them in a hypoxic environment, they're dead. They gave them a chemical to these rats, and they created a left-shifted hemoglobin to the rats. They put them back on the chamber. They did the same experiment. All the rats survived. Such a beautiful concept where you can see that manipulating the position of the curve has a major impact on oxygen delivery. We tend to stress this in our residents all the time. What does the curve does if you're acidotic or you're 2,3-DPG, whatever. I will tell you that unless you're dealing with very extreme physiology, it doesn't matter. In the sense that at the local tissue level, let's say you're alkalotic, for that matter, for whatever reason, you load your hemoglobin with oxygen. When you get at the tissue level, the milieu at the tissue, whether you're acidotic or hypoxic at the tissue level, will then offset whatever you have in the position of the curve and will basically override what is happening there. So the local milieu will have a major impact. It will be on very extreme scenarios where manipulating the curve may have a survival benefit, like these animals do have. Let me see what's going on. So we wanted to use those mole rats, and again, as part of the respiratory system theme, we wanted to see how the cardiovascular system will adapt when they were doing exercise, okay, during hypoxia, okay? And again, this is interesting because the lab had, I think, a group of like 20 mole rats. They were brought from Israel, whatever, again, very expensive animals to keep. And the pre-med student that was doing his thesis to graduate, to finish his underground studies, had managed to basically kill probably like 10 or 15 of these rats. Every time they did an anesthetic, the animal would die. Okay? And that's a problem. Okay? And this guy was desperate. If I don't complete this, and he's been already working a year on this project, okay? It would have been it. So they called an anesthesiologist to see what was going on here. Okay? I don't know what happened with it. So even if they did a local anesthetic, the animals would die as well. So they were clever to say, oh, general anesthesia doesn't suit them well, let's do local. They were dying too. Okay? So again, you look at your anesthesia textbooks. And these animals do have a lot of arrhythmias, well documented. Okay? And guess what they were using when they were trying to put them to sleep? Halothane. You guys don't see halothane anymore, but I'm almost certain you use halothane a lot. And one of the things that it's purported to halothane to do is to probably increase your arrhythmias. So what do? You switch to isoflurane. Isn't it simple? Now you would say SIVO, because that's all you guys want to use nowadays. Is that true? Well, the tech in the lab tells me, Dr. Martinez, we don't have high isoflurane vaporizers. We have halothane vaporizers. What's your answer to that?
It's okay.
It works? Why? Vapor pressure are the same. And that's when knowledge plays a role. That's when you, as being the expert on this field, can tell the tech, who cares? Vapor pressures are the same. The vaporizer should work well. Except that if you have an agent-specific vaporizer, you won't be able to put them together. You have to rig it in a way. The good news, vet anesthesia machines are not agent-specific, so you can do whatever you want. Okay? So that's the good news. So that's what we did. And look at how the anesthesia machine looks. Rudimentary, you got your flows here, but you can open, there's a little cap here that you can just take off and fill it up. And again, you can then substitute one agent for the other, and the output of the device should be very close to where you get it. And again, I have an attending that used to be very dramatic when he was giving anesthesia, and he would tell me, it doesn't matter. You want to give 1.5%, 1.3%, 1.9%, whatever. He would tape the vaporizer scale. So he would say, you're going to give enough. Which is, as a junior resident, I really felt a little bit uncomfortable with that. But the more experience I develop, I can see that you're going to basically give enough to obtain the response that you want. But in any case, I was very preoccupied with that. I said, and again, I think the arrhythmia issue was the main concern, so let's switch to halothane, to isoflurane instead of halothane. So these animals, interesting enough, were getting very cold. I'm almost certain when you do your PD rotations, the first thing you do is the room is warm, you got all these things and lamps. If you got those little preemies, oh my God, you go crazy with all the heating things. Because it's a bad thing. They have a high surface ratio to volume. So these animals are even smaller. They have a lot of heat loss. So we brought blankets and we brought heating things. We got temperature probes. I used to work in a lab where we had monkeys, and it was kind of funny because the monkeys were dying after the anesthetic. Guess what? The monkeys were like 89 degrees after the anesthetic, and they were basically having arrhythmias and dying, and nobody cared to measure a temperature. Basic things you would do to any PD case, or a human for that matter. That's why I'm telling you, it's very important that the skill sets that you guys have and the knowledge base that you have will help you a lot. And again, having an EKG is key, so we put little clamps on the little paws of the mole rat so we can have an EKG. So I had syringe, pre-filled syringe with dosages of things to give, antiarrhythmics. Okay, the lidocaine dose of 100 little gram thick. It's very tricky. I don't know how you do your PD cases, but I used to have like little syringes already pre-filled with everything, because it's very hard in the middle of an emergency to start calculating a dose. And we're not talking a 1 kilogram or 2 kilogram baby. We're talking a few grams. Then it's kind of interesting because the students were trying to use local anesthesia, and they would use lidocaine to infiltrate and try the cardiac sensor they wanted to place was a sub-Q device that you can put on the chest. You numb the skin and put the device in. So they were basically doing that. So they would give, 100 grams of lidocaine. Actually, they were injecting 3 mLs, which is not bad, at 2%. That's 60 milligrams, okay, which is 120 times the toxic dose of a little animal of this size. So the little thing was seizing. Actually, that was the first thing I told them. No matter what we do, this animal seizes. We give them halothane, they seize. We give them local anesthesia, they seize. So I said, well, look at what's happening. You guys are giving too much lidocaine as well. So if you want to save the remaining animals, what's the first thing an anesthesiologist does? Secure the airway. I do simulation with my students, and it's very interesting because there's something, well, that's what we do for a living, securing the airway, but it's interesting. The heart rate can stop. You can go asystolic, whatever. What's the first thing that you guys are going to jump for? The airway. I said, really? You need to do CPR first, chest compression, but the natural instinct is to secure the airway. And guess what? We need to secure the airway. Have you ever tried to intubate this thing? Okay? Not easy. The frontal incisors basically block the whole thing. So you have to develop retrograde techniques. So you get an angiocath, you hit their trachea, you thread a wire, and then you get the angiocath from the top and secure their airway. And we were prepared. These animals weren't going to die on me. Very simple. Okay? You don't want your patients dying. I know your chairman wouldn't be happy if you were having dead patients every week. This is the first animal surviving the anesthetic. He woke up.
This is a hand surgeon. We're going to ride more. Finally.
Finally. He was very desperate. You see no eyes. That's a heartbeat. You hear that? That's a heartbeat.
Strong and regular.
So we were able to then complete the series of experiments that we needed to do, and the student was very, very, very happy. So again, I just wanted to present to you some of the principles of oxygen transfer, looking at a little bit different facet, basically trying to compare what other animals have come up as a solution for a particular problem. I think we can say in general that the mammalian lung as such is designed to support the function that it's supposed to carry. I think the way we see failure is interesting. When you go back and look at those traces where you have diffusion limitation and you see that you cannot equilibrate, you can make the argument, the contrary argument, that as the gradient is enhanced, you have a bigger partial pressure gradient to push oxygen into the system, so the total flux of oxygen through the system is higher, despite the lower PO2 coming out of the system. Try to understand that. It's not the PO2 that I'm interested in necessarily, but the amount of oxygen really getting out of the system to the whole body. So even though the PO2 might be a little bit lower, by having a bigger pressure gradient, having an AA gradient pushing oxygen into it, it makes for a better oxygen delivery. So those animals will desat, and thoroughbreds will desat while racing, but this is maximizing oxygen transfer. So the concept of failure may be rethought again. And last but not least, I think you have to be grateful to give anesthesia to humans. They're not going to bite you, most of them. They're not going to disembowel you, that kind of thing. Humans will probably, sue you, And I think, most importantly, I think by better understanding the design of the respiratory systems in general, you can then see how our system is designed and the strategies that the body uses to optimize things and how to troubleshoot things. Some of the examples that I gave you prove to you that by having a wider knowledge base, understanding basic principles, we're able to troubleshoot some of the problems that they had with these animals. Any questions?
First, I want to say it was a fascinating talk. I have two questions. You talked about the systems of the small animals, the birds. Did you, or has anyone, considered the extremely large, the whales, the elephants, and has anyone extrapolated that to think about the systems of dinosaurs, or extremely large animals? And my second question is, you demonstrated the extremes that humans and other animals can tolerate. So, what are the clinical implications for end organ ischemia, neuroprotection, brain, cardiac protection, etc.?
Sure. Big animals, yes, there's a good body of work on big animals, giraffes and elephants. Whales is interesting. Whales I don't have any experience with. I wanted to volunteer in the Boston Seaquarium. I don't know if you've ever been in Boston. They have the animal hospital that they have there is at the entrance of the aquarium, and you can see the animals getting their treatment. So when I saw that, I said, oh my God, I need to work here. But it's not that easy. So I couldn't eventually deal with dolphins or whales or whatever, which have a completely different set of physiology. I did get a little bit of exposure with some of the Weddell seals. My chairman, Dr. Zapel, you probably know him, is an expert on Weddell seal physiology, and through his work we were exposed to that and all the adaptations that these animals would do. So whales do have a very specific group of adaptations. I haven't had any experience, but in giraffe and elephant physiology, yes, these principles do apply. They do apply, and it's very interesting because when you start looking at the system, they have also fascinating adaptations. Let me give you an example. Giraffes. What's the most notable thing about a giraffe? Their neck. So if you're just thinking about their neck, like, okay, what's the problem of having a long neck? Dead space. Okay? So you start thinking, whoa, this animal should have a horrendously increased dead space. So if you look at the minute ventilation of these animals over time, you will realize that the minute ventilation of a giraffe, if they were to compensate for the increased dead space, would be a high minute ventilation. If you look at their minute ventilation, it's not that increased. So either they're hypercarbic, which they're not, or they have something else going on. So when they dissect giraffes, they notice the following. And for example, one of the ways to measure dead space in a giraffe sounds a little bit raw, but they kill the animal and they fill the airway with water, and they measure the amount of water they need to fill the airway. So that's good assessment of dead space, okay? But they notice there's something very interesting, that these animals, given their body size, the same thing of allometer that I was telling you about, should have a trachea of a certain diameter, given their body size. And that fits nicely through all the gamut of weights. But as soon as you get to the giraffes have a narrow airway compared to the body size. So one way to cut down on dead space is to have a narrow airway. To the point now that now your concern is not dead space, it's airway resistance. Okay? So when you do the calculations of peak flows on a giraffe when they're running, for example, when they're exerting maximal peak flows, theoretically these animals should be choking as they run. They have what is called expiratory flow limitation, which is a true phenomena that you will have even in humans in certain circumstances. But these animals run, and when they're being chased by a lion, they run. They don't choke and die. I've never seen a giraffe doing that. But again, yes, animal physiology, big animals is there, and I think they fit most of the things that we're talking about. You were talking about extreme hypoxemia in humans and the clinical implications. I think we're learning more and more on some of these issues. I don't think we can agree right now on where we're heading with this, but there's some ischemic preconditioning that is happening at different organs. Things like a blood pressure cuff applied to a limb producing intermittent ischemia may produce certain production of compounds that may have an ischemic preconditioning in other organs, your heart, your brain, things that we don't understand at this point. Okay? I think we don't know for sure. We are very familiar with the precondition phenomena at the heart level, as you probably heard, but the precondition may happen in other places of the body as well. How do you translate this clinically? I don't know. It's going to be very hard for us physicians to produce ischemia. Oh, we're going to drop the PO2 in this guy to 30 so we can precondition and then going to bring him back up again. I don't see that happening anytime soon. But I think there's some signs there. That's why the permissive hypoxemia may be something that you may be hearing more in the future, if you ask me. Any other questions? Well, thank you.